Good morning, everyone, and welcome to today's presentation, A Closer Look at Dementia with Drs. Nelson and Dr. Jaika. I am Terry Weber with the Work-Life Elder Care Program. But before we get started, I'd like to thank Sanders Brown Center on Aging for one, letting us use this really beautiful space, and two, for partnering with us to offer Dementia Caregivers Week. Thank you. I appreciate it. So without further delay, I'd like to introduce Dr. Nelson. Today is going to be just a conversation. So if you have any questions, you can just kind of feel free to pop on in or put it in the chat box and we'll get to that later. Thank you.
Well, good morning. Thank you for having me today. I'm going to try to speak loudly. I have to wear a mask today because my daughter just came down with COVID as of last night. I tested this morning and I was negative. I'm going to wear this mask up, but I'm not going to be shaking hands or whatever, and we'll just try to keep a little bit of distance here. The reason I'm here is that I work at Sanders Brown at the Alzheimer's Disease Research Center. I'm an experimental neuropathologist, which basically means that I do the brain autopsies, and then I try to study scientifically and analyze the implications of the results of those autopsies. So that's what I do. I'm going to click this thing off and let you do the admitting from here on out. So what are we talking about today? We're taking a closer look at dementia, and I'm going to sort of give you some idea of some aspects that could be useful to you. And also going to convey a little bit, a small sliver of what we do at the University of Kentucky. We do so much more than what I'm going to say, but I'm going to just present a little bit just to give some idea of what we do, why we do it, how we do it. People always want to sort of know what motivates you. We're going to get some indication of that, a little primer on the normal brain and the dementia brain. And then again, we're going to talk a little bit about what we're doing about it here at University of Kentucky. I'm going to sort of go from a very simple cartoonish version to a little bit more complex. And if you guys have any questions, please don't hesitate. I'll be happy to answer anything. Special shout out, by the way, to anybody that's a veteran or on this Veterans Day. We appreciate all y'all. Always appreciate caregivers. Caregivers are such a vital link for everything. So much of the weight falls on them. It's horrible to be suffering these terrible diseases, but the weight of it really shifts from the patient to the caregiver to no small extent. And so we appreciate that. I was just talking about, as doing an autopsy, we interact with the family to some extent, and I'm always just so grateful about the enthusiasm and the empathy and sympathy that they have given to this whole process, and we're all sort of parts of a big team. In terms of what motivates me personally, my grandma Tibby had Alzheimer's disease. This was really formed my life. It was a dreadful thing for my mom. It's an amazing privilege for me to be able to fight every day the thing that tortures her, both in her memory of her mom and what could happen to her. And unfortunately, my dad a couple of years ago also passed with dementia. So it's really scarred my life, and it's a big aspect of what I do. So in terms of what we do here at the center and what motivates us is to primarily respect the research volunteers that are here. It's a huge team, really. There's so many aspects of it, whether it's in diagnostics and therapeutics and science and research, but the core of it is really the research volunteers. And that's a team. The caregivers that participate and the co-participants with the research volunteers are every bit as important as them themselves. And really, it's a community and academic and a group of people that have been going for decades. That's what makes you so strong. And that enthusiasm of the research volunteers is critical. Respecting that, especially as part of the team that does the brain autopsy, I think it's particularly critical. And secondly, it's defeating dementia. That's the fight. That's what we go. That's what I get every day. I go to bed thinking about. I wake up thinking about it. That's the fight. That's the part that we're in. As I said, it's a huge privilege for me to be part of this fight against something that tortured my family and so many people. But it's not like unfortunately, that it's just some weird thing that randomly hits you. It's something that is a 1 in 2 people. So looking around this room, everybody from here over is at risk, or everybody from there over. Like, it's something that's not abstract, it's not unusual, it's shockingly usual at the time when we should be enjoying the fruits of our labor and relaxing and getting off. So many people, unfortunately, lose their brain, their mind, their memories, their ability to think and do stuff. And so this is what we're fighting. And I sort of think of everybody here as on that team as well. We're working together in a common cause. We all have different skills, we all have different abilities, we all have different things that we can add to this fight. But I think it's an important one. And it's one where dementia has been a little bit slow on the uptake. Cancer has been more, the cancer research field has been more interventional, more able to give patients choices. We're only now finding that point where we are starting to make choices, give them to patients. It doesn't mean that everybody has to participate in clinical trial, but everybody should be given a choice. And that choice is something that's been, I think, we've been a little bit reluctant to give them. And I think that people need to know the choices that they have more than they are right now. Now you say, oh, you're 75, you're 85, you're warehoused, you're moldering in a space where you're unable to help yourself, unable to help the world. But I think that in the cancer field, it's not like that so much. People are given that choice to participate. Some of them will get better, some of them won't, but they're given a choice to participate in the process of making things better for themselves and for the next generation. And we're only now getting off the schneid in terms of getting that into patients that are at risk for dementia and the caregivers that are their sort of helpers. So that's sort of the backdrop. What the field is sort of evolving to understand. And so I've highlighted recently and complexity. Why? Because it's recent. It's really every researcher over the past decade or so has really evolved. It was even 10 years or so ago, it was considered that you're only having one disease of brain aging that's associated with decreased memory and cognition. That amazingly childish perspective has evolved a great deal. And actually our center has been a big part of that, of taking us from a position where we just say, there's just one disease, that's called Alzheimer's disease, to an appreciation that it's far more complex. And that grappling with that complexity is going to be the key to making progress. It's like in cancer, even a lung cancer, you have lung cancer, you're like, huh, what type of lung cancer? Because some lung cancers respond to some therapies, and some respond to other therapies, and some respond to no therapies. Yet, but in order to grapple with getting those ones treated, we have to say what's special about those horrible ones. So it's grappling with that complexity of understanding that it's more than one thing gives you impairment about brain aging. And this is the most complicated system that we know of in the whole universe, which is the human brain. That different populations may have different exposures and risks. So I can start with a primer about how the brain works. This is not exactly exhaustive, okay? This is not exactly exhaustive. But this is how it works. Basically, a neuron, of which there are about 100 billion in your brain, but this is just one. This is basically how it communicates. There's a processing central unit called the cell body. There's a telephone wire where it goes to talk to its neighbors or even regions far distant, and then there's a telephone. So you got the processing region, telephone wire called the axon, and then the telephone called the synapse. And then it talks to another neuron, and it talks to it over a place called the synapse. So that's where the phone actually gets connected to the other neuron. That's how, in a sense, the whole nervous system works. By this going over again, 100 billion different neurons, and each neuron has, on average, 10,000 of these synapses on it. So this does not encapsulate the complexity of it, but it gives you an idea in a cartoonish way how neurons communicate with each other. Now, what else is going on in the brain? Well, proteins are really important. Proteins are what confers both structure and function in the brain. Structure gives you delineates different spaces and makes it so that you have actual form. Whereas function is catalysis of enzymatic processes. Proteins do both of those functions. So now we've talked about neurons, how they talk to each other, and proteins. Well, what goes on in Alzheimer's disease? Normally you have this very fine-tuned small machines called proteins. In dementia diseases, they get misfolded, they get messed up, they get very insoluble, they clog everything up, and what I call glop, and it's a very non-scientific term, but they become the very fine-tuned little machines become gloppy. And I'll show you that how it looks like on the microscope. But the key point is both the structure and the function get messed up by this gloppiness to the protein. That's a common thread for the different neurodegenerative diseases, is this gloppiness, this misfolded, nasty proteins. Which begs the question if we could bring together both the neurons and their function and the proteins to ask, when you have a neurodegenerative disease, can folks on Zoom hear me? Am I being loud enough and clear enough with my mask on? I just want to make sure people are
Thumbs up.
thumbs up. Okay, I'll try to keep clear as much as I can. It's a little bit of a challenge with the mask on. In neurodegenerative disease, how do we tie together these neurons that are supposed to be functioning by communicating with each other and the proteins that are supposed to be functioning for structure and function but become gloppy? Well, here you have again our neurons talking to each other. In the course of neurodegenerative diseases, there's glop in the cell bodies. There's glop in the telephone wires called axons. And the synapses get chock full of this glop and they are killed. In fact, your brain goes from being around 3 pounds down to being 2 pounds. So there's a 30–50% decrease as this brain gets atrophic and starts to get destroyed. And it's this gloppy proteins that are the critical aspect. Dr. Jike is going to talk to you more about some of the things that we do to try to fight those gloppy proteins. But the question is one of the things as a pathologist, we look at this in the brain and we say, what does it look like? And you can't just tell from looking at that atrophic brain that went from 3 pounds to 2 pounds. Yes, it has shrunk. Yes, part of it's destroyed. But you can't make a specific diagnosis of what caused it to be destroyed. You have to look on a microscope. So for every autopsy, we dissect the brain, take little pieces of it, cut them very thin, and then stain them for specific proteins and for specific types of pathology. And so I'm gonna give you an idea of what it looks like. This is a normal brain. This is what all the people in this room no doubt have, this normal looking brain that's stained blue, pale blue to show you the neurons. This is what the actual neurons look like. This is blown up. This whole microscope field is a little bit under a millimeter. And what you can see is a lot of the space is taken up by what looks like nothing. But remember, I told you that there are these telephones connecting with about 10,000 synapses per cell. This is where that action is going on. This is where the connections points are between the cells, are out in this space that looks like nothing is going on. In Alzheimer's disease and neurodegenerative diseases in general, that space and the cells themselves get taken up by the gloppy protein. And so let me show you. So this one is the normal person, died with cancer, nothing to do with Alzheimer's disease. And died with a cognitive intact. This is somebody who died with Alzheimer's disease, stained with the same stain as that one was, but now you can see the gloppy protein. It's taking up both the space that is usually should be taken up by the cells and by that extracellular space that has the synapses and the connection points. So that gives you an idea of the process of degenerative diseases where the gloppy proteins start to take up too much of the brain. In the case of neurodegenerative diseases, different gloppy proteins exist. And so one is called A beta, one's called tau, one's called TDP43, and one's called alpha-synuclein. These are different proteins that nonetheless all have the common theme that they become gloppy. But the sort of the interesting thing is that different neurodegenerative diseases are associated with different GLP proteins. So there's going to be a test on this, by the way, after y'all are done, we're going to have to be tested. Alzheimer's disease has two different GLP proteins, A, beta, and tau. Those are the two those are the first ones that were sort of invented by science. And these are what happens in Alzheimer's brains, A, beta, and tau. Parkinson's disease and dementia with Lewy bodies, Robin Williams, sort of the different neurodegenerative disease, that's synuclein, totally different protein from the Alzheimer's protein. And Bruce Willis, he has FTLD, or in people with ALS, they have TDP-43 pathology. So it's sort of an alphabet soup. It's sort of confusing. But the one that we're going to talk a little bit more about, in which we've made a lot of strides here at University of Kentucky, is called late. And this is the disease I'm afraid that maybe affected Hal's family, who was talking about, that it really seems to affect people later in the aging spectrum, at the very ending point, with a slightly different cognitive impairment trajectory. It's sort of a alphabet soup, like I said, like limbic predominant, age-related, TDP-43, encephalopathy. And you can dissect that. Limbic predominant means the aging centers of the brain. Age-related is it seems to go up in very advanced age. TDP-43 is a protein. Encephalopathy just means brain disease. But you can just keep it to late. It's good. Disease is called late. We did a lot of the advancements in this disease right here at the University of Kentucky, and the lifetime risk for it in the community is 1 in 4. So 1 in 4 people, so several people in this room are at risk for late. And it definitely is very prevalent, and it has a strong impact. I'm going to talk to you a little bit about some case reports here, because this is something that affects human beings. It's not an abstract something in a classroom that doesn't actually occur. This is a person who enrolled at our center at the age of 77 and was followed for 25 years. Every year came in for clinical visits. And you say, wow, that's incredible. Just this last week, I did an autopsy on somebody who was 22 visits. So this is fairly routine. People that have been followed since the 90s, they're now coming to autopsy. It's also an incredibly rich and valuable source of information for our field, for researchers. So this is the mini mental state exam score. A lot of you know about this. It is a 0 to 30 score that gives you an idea of global cognitive status. For people that are unimpaired, the top is 30. For people that are severely impaired, it goes all the way down to 0 for people that can't respond to the test. So 30 to 0, this is the patient's age. These here, so the y-axis is the test scores, and the blue line demarcates her test results over the years at different ages of her life. At the age of 91, she became mildly cognitive impairment. Her cognitive status went down. You can see this taper at the end, and she died with Alzheimer's disease diagnosis. So this was a long-standing person that was followed for a long time. I just want to emphasize that these are powerful, powerful data. We get so much information. We get genetics, we get neuroimaging, we get detailed neurocognitive, we get an assessment of all their medical and clinical data all through this whole process. All their risk factors, their genetics are extremely detailedly figured out. And so all sorts of risk factors and correlates are understood. Now you multiply this by 1,000. And now you start to get, just from the University of Kentucky, an amazing trove of medical data. Then we take the brain autopsy and we send it to people around the world who also have access to the data. And we send dozens every day to people all around the world to complement the fight against dementia. And so this person, though, came to autopsy, and there was although she had a clinical diagnosis of probable Alzheimer's disease, there was no Alzheimer's disease in this brain. It was all late. Different disease. So the GLP protein in this case was TDP-43. not the gloppy protein of Alzheimer's plaques and tangles. Different genetics, different other risk factors. If you want to have a therapy, an Alzheimer's therapy won't touch it. Knowing the difference is critical for getting progress. So this is TDP-43 pathology. And we'll go to another case. This person was enrolled at age 65 at the University of Kentucky. He was followed for 27 years. So again, you can see this somewhat fluctuating course. Like maybe here he had flirted with depression or had some big something going on in his life that he was in a great bad feeling about, or had a cancer or something like that he fought through. That will affect your cognitive test scores, even if it doesn't affect your brain so much. But then he banged back and then he went down. So you can see that there's not that much of a huge difference between these two contours for these two individuals. A lot of times an individual doesn't follow the rule books. But this person had Alzheimer's diagnosis by the age of 84 and was severely impaired when he passed away in his early 90s. But this person had both Alzheimer's and late. So two different conditions. Unfortunately, all too common. So not just one or two, but three different pathological combinations. And this, unfortunately, is the most usual combination. The thing that we have usually clinically, sort of classically connected with the Alzheimer's disease clinical scenario, plaques and tangles, is most often all three of these things. And we need, in our sort of clinicians and our research enterprise hasn't really caught up with that fast. And who cares anyway? It's all just an alphabet soup. All you got is all this stuff. You got squat, blah, 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 blah. Well, actually, it matters. So let me just give you some terminology here. So Alzheimer's disease, ADNC, is Alzheimer's disease neuropathologic change. That's the plaques and tangles. Late NC is the TDP-43 pathology. And I'm going to give you a little whiff of the concept of epidemiology. Epidemiology has really come into fore with the whole COVID crisis. Who's at risk? Who's at not risk? Is vaccines good and vaccines bad? Is it okay to get the disease? Is it not okay? Who's more at risk? Who's less at risk? Who's getting it? You know, and it's sort of been polluted by politics and all this other stuff. And in fact, it's generally usually controversial anyway, because people sample different populations. It's just basically the study of diseases in populations, and different populations are different. So some person will study this population and find this. Some person will study that population and find that. They'll be different, and they'll say, hey, you're wrong. No, you're wrong. Well, maybe they're both right. They're just the populations are different. And so it's a complicated thing, and it's no less complicated in the area of dementia, where in order to get the definite diagnosis, you have to have an autopsy. And now most people don't get autopsies. Almost nobody does. It's one of the great things about our Alzheimer's Disease Research Center is all the participants basically get autopsies, so we can get the gold standard understanding of what befell them. But in general, that's not the case. And so over time, over these past years, we've had these assumptions about what these clinical phenomena are that are somewhat divorced from the reality of what's actually going on inside the brains. So the epidemiology is kind of messed up and confused. But that's what we're getting at here. So here's my point. So this is percent. This is 100 up here with the y-axis. And these are age ranges. This is 70, 75, 80, 85, 80, 90, 100. And this is different severities of late. Late keeps on trucking up in really severe advanced old age. And this gets to Hal's GMA. Alzheimer's disease in its severest form levels off and even decrease in advanced severe old age as the ApoE genotype poops out. That really gets expressed in the 70s, 80s, early 90s. But by the late 90s, Alzheimer's disease is pooping out, and it's really late is going to be the more common of the two. So that's just something where epidemiology gives us that information. Here's looked at it a different way in a study that was pioneered by Dr. Aaron Abner, who is our wonderful data manager, director, co-director. And so this is looking at the proportion of people with dementia right here at the Alzheimer's Disease Research Center. And of these dementia people, we always classically thought that's the plaque and tangle person. That person's got plaques and tangles. And yes, most of them do have some plaques and tangles. But the proportion that have pure plaques and tangles of Alzheimer's disease is only 19%. 19%. So that's about what proportion of people respond to the new anti-amyloid therapies, which makes sense because these are the people that only have the thing that the drug is being designed for. So by contrast, the percentage of people with late and Alzheimer's disease together is around 46%. So that's like a much more common combination than just pure Alzheimer's disease. So this is data from our center that is probably the best in the world. In addition to that, you remember I showed you those charts of the people that have been followed for dozens of years that had the cognitive trajectories laid out for you. And I said, that's a really valuable thing because you can get so much great information from that much data, that long follow-up of cognitive changes over time. And this is what you can do. You can look at them, these people that have been followed for more than 10 years. And this is the right side is the x-axis the years before death. And 0 is on the right side. And this is going back to 12 years and before on the left. This is the cognitive trajectory, basically. So pure late has a relatively benign course. It does give you dementia eventually, but it takes a long time. Pure Alzheimer's disease is worse. It's more swift and severe. But the combination of the two, when they add up, they tag team, they're more swift and severe than either alone. That's that sort of swift person just going down and down, 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 down in cognition and memory. That's that combination. And that may be more refractory as a practical issue for the clinical scenarios to the Leqembi type of anti-amyloid therapy that we're coming out with. So this shows that when the rubber meets the road, it's actually important to know these combinations, and we need to develop biomarkers to detect them. So in other words, so here's cognition on the left. This is sort of analogous to the charts that we showed on those people that we followed for a long time over time. And it shows you with late, the same trajectory gets more severe. It augments the problem. So it's kind of a bummer in a way, because you jump out of this burning building, you don't just have Alzheimer's, that's great. And so you're like, uh-oh, and you sort of, so it's like, just because it's kind of a bummer to think that there's more than one thing out there. However, on the one hand, it's reality. And if you don't deal with reality, you're doomed to fail. And on the other hand, each one of these new diseases is an opportunity in itself to develop a therapeutic approach, a therapeutic strategy, a way to intervene and preserve that which cognition which exists. That make sense? So that begs the question though, okay, you just found out that there's something called late, and it's not Alzheimer's disease. It sometimes happens with Alzheimer's disease. All too frequently it happens with Alzheimer's. In fact, if you want to know the answer to the trivia question of what portion of people have some plaques and tangles, about 80% when they're 80, 85 years old. But only about half of them have severe enough Alzheimer's that it's really going to push it real hard. So these days of saying you're 1-0, yes, no, Alzheimer's, that's sort of over. Because it's really, how severe is that Alzheimer's? How severe is that pathology that matters? It's the complexity, it's dealing with the complexity. And I know that everybody sort of has a wake me up when it's over attitude. You're the scientist, you just tell me what to do. But it's also good sometimes to be aware of some of these complexities so that you can sort of keep them as part of your decision-making process, however you're dealing with people. And however you're caregiving. So I'm going to get into a little bit of science weaniness about some of the stuff we're doing here. It's just one small little tiny little figment of what we're doing here. But I just want to sort of convey some of the process of how progress gets made and some of the things that we're doing right here at the University of Kentucky. So to discover mechanisms, so something like 80% of risk for dementia is genetic. If your mom, dad, sister, brother, granddad uncle, whatever, they had it, that changed or doesn't have it, that changes your risk quite a lot. So about 80% of the predicted risk comes right through your genes. But it's different. Some people are at risk for this type of dementia, some people are at risk for that type of dementia, some people are at risk for both types of dementia, and they are interacting. What we did right here at University of Kentucky, the very first late genome-wide scan. What that means is we took thousands of people from all around the world who had genetic characterization and pathological characterization and compared the people that had late from the people that didn't have late. The very first GWAS, actually, I think, the very first large-scale GWAS that was centered in Kentucky ever, and it was done for about late. And we found that an association between a gene called ABCC9, which is interesting on multiple levels, including the possibility to accomplish one of the great underachieved goals of genetic studies in general, is to have clinical relevance. To basically go from this computer screen giving you a p-value into the clinic right here where people are, and give them something that maybe prevents this catastrophic pathology. Because it's a druggable target. That's what's cool. So this is sort of a representation. Remember, I showed you those proteins or specialized machines inside the cell. ABCC9, every gene, many genes are, their job is to encode for a protein. That's what genes do. This gene encodes for this protein. This is sort of a picture of it. It's sort of a tube, it looks like, and that tube is pretty small, but it resides on the membrane of the cell, on the surface of the cell. So it encodes here and it opens or closes, and then it has a complex mechanism that I'm not going to talk about too much, other than to say there's a drug that works directly on this protein that opens up this channel and produces a more healthy cellular environment. The drug is called nicorandil. So nicorandil is a drug that's used around the world. This is one of the many clinical trials with nicorandil. This is sort of survival on the y-axis over time. These are people that are at great risk. They're being given nicorandil because it's also used for unstable heart disease, which is a very high mortality condition. The people with nicorandil hung in there pretty good. The people without nicorandil fell off quite a bit more. So it's actually a healthful drug, not just for the condition that we're talking about here. It produces an intracellular, healthy microenvironment. So you guys may recognize this cat right here, Dr. Jaika. He just poked his head in over there and said, hi. He designed, we designed together a clinical trial to provide nicorandil to people who are at risk for late. People who don't have Alzheimer's, but do have a biomarker profile that's compatible with late risk. We think that that's pretty cool because right now we are screening thousands, hundreds of thousands of people across the country for their risk for Alzheimer's type pathology. Why? Because the people with A-beta amyloidosis are candidates for treatment with an anti-A-beta therapy, Leqembi, which is extremely exciting. It's so exciting to me that we're getting in the win column. We're screening people for their blood, for their cerebral spinal fluid, for their neuroimaging features of A-beta amyloid, which means that the A-beta deposition that I showed you in that picture earlier on, the big blotchy blobs, those are starting to develop in the brain. So you're at risk for developing Alzheimer's disease. That's the candidates for taking the Leqembi. That's the people that are the targets for that. But if you screen about a population of people that are slipping mentally, their cognition are going down, a third of them will not have any of that. They will have a brain free of amyloid. Those people are at serious risk for late. That's called a screen fail. You have failed your screening test for Alzheimer's amyloid. So, we tell them in general, across the country, across the world, see ya! You got something that we can't do nothing with. You are, in a word, toast. But here we have a clinical trial led by Dr. Jaika and his team to use a drug that says, hey, sorry, you're not hope. You have an opportunity to take a medicine that gives you hope for preventing the clinical features and the brain destruction that goes along with late. So that's kind of cool. Right here at University of Kentucky. So late, what is it? Why it's important? It's a common brain disease of aging that mimics or worsens Alzheimer's disease clinically. Our center has pushed this field forward very strongly. How we might beat it? We did the first genome-wide scan here at Kentucky, and we have the first clinical trial here at Kentucky that's funded by the NIH to address this problem in people that are at risk for it. My conclusions, and I guess I'm stopping a little bit early here, but I'd be really happy to take questions. Dementia is, in a word, complex. It's not just a disease. Dementia is not a disease. Dementia is like shortness of breath, which is not a disease. It's a symptom. It's a clinical syndrome. Many different things give you shortness of breath. Most of them are not cancer, but cancer does. Most of them are not infectious, but sometimes infectious, inflammatory, all sorts of different things. So you say, I feel short of breath. Is it a heart problem? Is it this? Is it that? Other things can cause shortness of breath. So you go into your doc. Dementia is the same thing. Just because you have cognitive impairment does not mean you have a disease. It means you have a syndrome. And you need to get tested for the diseases that put you at risk for that syndrome. And when we do grapple with that complexity, it's always a drag when things are more complex. Everybody like A, arrow, B, arrow, C. And everybody likes that because it's like our little humanoid primate brains can deal with it. But guess what? That's not the way it is. It's just not simple. And if you want something simple, you got to go someplace other than the most complicated thing in the whole universe that we know of, which is the human brain, especially in aging. So this is the neuropathology core. These are the unbelievably wonderful people that I get to work with every day. And this is my boss, Dr. Ben Eldick. I believe strongly you've got to choose your bosses carefully, and I'm very happy with her. And a key collaborator, Dr. Jacka, who you will hear more from in a minute. I'm going to have to bug out for his talk because I don't want to give anybody considering to go home and work from home today. But thank you.
Thank you.
Thank you.
Wow. So there is a clinical trial for late.
Yes.
And so when you do a clinical trial, you find out that you are a candidate for this. You will find out that yes or no, you have that gene protein thing.
No, what you're going to find out is basically, are you at risk? Do you have Alzheimer's? Do you have Alzheimer's type changes? Because the biomarker has not caught up with the complexity of the pathologies. So right now we have good biomarkers. So a biomarker says you're alive and we don't want to have an autopsy of you, but can we predict what we would see if we did have an autopsy of you? So that's what a biomarker predicts. A biomarker is not a prediction of your clinical status, because Dr. Zyga can very ably, even I, can take you and say, do you have Alzheimer's right now? That's not a biomarker. That's just looking with my eyes and asking you what day it is. And you say, I have no clue. And you say, well, you probably are a little bit impaired. And so a biomarker does not diagnose your current status. Your diagnosis of a biomarker is to say, what is your brain changes that predict your future status? And so right now we're pretty good with the A beta and tau of Alzheimer's. And so we can look in your spinal fluid, look in your blood, look at neuroimaging called PET scans, and say, do you probably have Alzheimer's type amyloid and tau? The way that we rule in for this particular clinical trial is to say that the people that are negative for amyloid, but still have some degenerative changes going on in their brain according to an MRI, and maybe they're wobbling cognitively, those people are candidates for inclusion in this particular clinical trial. That make sense? Well,
It's
work with
sinking in, it's sinking in, it takes a little bit.
I'm sorry, sometimes I talk in shorthand and
No,
it's nice to be able to talk to folks that are in the community doing stuff. This is where the rubber meets the road. And so it's incumbent on, Dr. Jack is very good at sort of relating to people because he does that as a living. I'm more of a lab rat, and so this is a little cave doing my little stuff. So how can I make it more clear? What can be clarified?
Oh, I mean, just more or less needs to sink in.
Okay,
Science.
no
So
problem.
that's.
No problem, I got it.
And insurance, that's. I know, I understand that, I've asked people, insurance will not find out through clinical trials, they're very well protected, right?
Insurance.
Is it like my personal insurance?
Oh.
To know that in the future, oh, this person is gonna need a lot of care
Right.
because they are going to be having Alzheimer's / late. And so we may not want to carry her.
No, they won't know that. But I mean, that is something that the fight needs to go on because they will fight to try to get all the information they can. Like if I say that I'm going to sign up for insurance, they're gonna ask me whether I smoke, whether my blood pressure is high. And there's a sort of a slippery slope between that and what's my A beta content,
Yeah.
So like, once you start getting some clinical data and they are able to do that and it sort of makes sense that they would want to, but preventing them from getting your details that they have no business getting their hands on is a project, and it shouldn't be acted as though they're not gonna try. Yeah, they will try.
Do you think that puts people off for clinical trials?
I think if they believe that we are gonna take it for granted. Basically, if people think you're lying, they never trust you. Because that's the essence of trust, right? Is telling the truth. And so if you say, oh, 100% sure nobody's ever gonna want to know your information about your data, then people are gonna say that that's a lie. That's obviously a lie. So it maybe there's more trust from acknowledging reality and being truthful about it and saying that at this point, no, they don't, and we're gonna fight it. So insurance companies want to know your risk. That's their business basically, is getting risk and money matched.
Yeah.
Any other questions? Either from chats.
My father has been diagnosed with dementia, Alzheimer's. My uncle, dad's brother, deceased, had ALS. Is there any testing that can determine my risks of these diseases?
Yes, so a neurologist can work you up. ALS is a different barrel, but there are connection points between the different dimensions. And a prior diagnosis may have been wrong. And so I would encourage you to, if you are nervous, to see a neurologist and to try to get worked up, because there's no real shortcut. The imaging, the biomarkers, and the cognitive assessment, and also your genetics, I think, are all things you can get more information on. We're really, I mean, the thing is, it used to not matter. It used to not matter because you were basically asking to go someplace to be told that you're screwed or not screwed, which I think is valuable information to know about your prognosis. But now you can get into both a clinical trial that would give you hope, or just take actual drugs that work under certain circumstances, but not under other circumstances. So all the more reasons why there needs to be a culture shift where old folks get into the clinic. And where clinics and clinical trialists intelligently work with them and let them know what their options are, which has not been a part of our culture. People are warehoused and acted as though they have no choices when they do have choices. And I think Dr. Jack is going to sort of push that a little bit more practically denied.
We have another question. What is the role of an MRI in diagnosing Alzheimer's or late?
So an MRI, one of the things that the MRI detects is cerebral vascular disease. That's what it's great at. It tells you if your vasculature is not working right, if you have a risk for stroke. That's neither late or Alzheimer's disease. And that lets you, the thing about that is that minoritized populations are at greater risk, and you can actually do interventions that work. If your blood pressure is high, you are at severe, massive risk for cerebral vascular disease that can be detected with an MRI nicely. And then you can have a treatment plan for controlling your blood pressure. This is something that directly and most severely affects minoritized populations. And it's just, that's the greatest thing of an MRI. But for Alzheimer's versus late, it's also useful. So for late, there's a particular part of the brain that serves a function of consolidating short-term memory. It's called the hippocampus. It's the medial temporal lobes. That's severely hard hit and late. And if you see that pattern, then you're at greater risk for late, whereas the pattern for Alzheimer's is a more generalized atrophy in the brain. So the MRI can actually give you a ton of extremely useful information.
Good answer. Another question. How does one determine which syndrome they have within the cognitive impairment realm?
That's the neurologist's job. I mean, you can sort of web surf the Mayo Clinic or whatever it is, or WebMDs or whatever, and so everybody does it. I think it's a good thing to do. And Dr. Jacob may contradict my opinion to these things, but really, this is the answer to that question. He enters stage left as you ask it. They say, how do you work up and understand what your clinical syndrome is? And the answer is, in a word, Dr. Jacob.
We had a comment, great explanations for the lay person. And I didn't get to read that. That's a limit.
Good question. How long has the clinical trial been going on? What's the timeline?
It's a 2, so people will be on drug for 2 years.
Okay.
It's basically going on for 3 or 4 years. It hit the COVID nightmare, which was when one of the, there are many things that COVID did bad, but one of the things it did bad is makes clinical trials really hard. The primary rule of all doctoring is primum non nocere, first do no harm.
Yes.
So the notion of inviting people in here to get a disease that would kill off a whole nursing home was not appetizing to anybody, and it was a big nightmare for this guy and his team to figure it out. So it basically has bumped along through the COVID, and now it's recruiting as fast as it can.
There was another question, and I'm going to try to remember it. You had mentioned that depression can affect cognitive scores.
Yeah.
Can anxiety do that same thing?
Yeah, anything that puts you off your ability to think straightly and clearly will affect your test scores. On the other hand, it's possible sometimes that anxiety and depression can also indicate that you're at risk for a cognitive impairment syndrome of another type. So these are all things that can be in different scenarios very different. If you lose a spouse or you're grieving, these things are very natural, and those things can happen. On the other hand, sometimes the centers of your brain that are involved with regulating your emotional responses, they can be thrown off kilter by a neurodegenerative disease. And in those cases, sometimes these sort of neuropsychiatric manifestations can be sort of a harbinger of a different sort of cognitive impairment syndrome.
If you have a parent who is showing signs of cognitive decline, what are the first recs for exploring, i.e. PCP, neuro, etc.?
So again, this is the answer to the question. Basically, getting worked up by a pro is a good idea. The thing that he would do is try to rule out the things that would explain it, whether it's hormonal or other aspects of
of life changes that could be treatable if you're having depression, you're having a thyroid disease or something like that. There are a lot of different things that can put you off kilter, but in many cases, there really is a process going on that needs to be worked out by a good neurologist. And so now that we have the opportunity of maybe affecting them, but preventing them, but for the first time, getting a win and getting some people that are at risk and preventing that risk from coming to a fulminant tragedy. That is really what's important. And it's so, it makes it even more tragic that there are going to be people that miss out on it because there's not a culture of therapies. And we were talking about it before that minoritized populations are especially at risk for this, that they have very, very sound reasons for distrusting the medical establishment. They do. And it's so much more tragic that will now cause, that distrust will now cause people to suffer more. And so that's something that we need to fight and to muster all the force we can to get people to know what their options are.
And one more.
One
Okay.
more.
All right. Regarding cognition tests and scores, you stated that depression or cancer diagnosis can impact score. My husband is currently battling multiple type cancers and depression. I have noticed a sharp decline in the latest round of radiation. Is it usually a temporary decline or can it continue to decline?
So there's something called chemo brain that is a result of inflammatory mediators in the brain that are whipped up by some of the therapies, whether it's chemo or radiation or the combination, and the cancer itself can do that too. So I would say in a situation like that to hang on, fight it as hard as you can, and think about the cognitive aspects later. And to really, it seems like he's got a big battle going on. So take care of that. Don't let that add to the stress, although it no doubt will. But try to address the pressing issues now. And it's very, very normal if you have a dreadful health problem, whether it's cancer or others, to fight it with a perky attitude. But the perky attitude does help. It really does.
Okay. Endorphins.
Yeah.
Endorphins.
Yeah. And I don't know. Dr. Jekyll knows a lot more about this stuff than I do, but the fact is that there's cycles of sort of going up and cycles of going down as much as you can to have exercise, have sleep, have dietary and other aspects of your life and that are positive that can charge you up. And so it really is humbling to talk to caregivers because caregivers are such a big part of that. They are what are a big part of our team here in our clinical research. They're a big part of everybody's life. They don't get the credit they deserve. And I'm just so grateful to you all for helping the caregivers, for the caregivers themselves. And please don't hesitate to reach out if I can ever help, if I can ever do anything. I'm sorry I have to be masked today because my daughter has COVID and I'm tested negative today, but I'm going to bug out for now so that because I don't want to expose anybody needlessly. But unless there's any more questions.
Nope, there was a thank you. That was the
Okay.
next comment.
Thank you all
Thank you
for
very much.
for-